Order. I call this meeting to order. This is the Standing Committee on Health. My name is Suzanne Lonis-Croft. I'm the MLA for Lunenburg, and I'm also the acting chair of the committee. Today, we will hear from the Nova Scotia Nurses Union regarding its report on nursing potential. I'd like to remind everyone to turn your phones off or put them on vibrate. In case of an emergency, please exit through the back door to Granville Street and gather across the street. I will ask the committee members to introduce themselves, starting with Ms. DiCostanzo.
Thank you, and good afternoon to everyone. Rafa DiCostanzo, MLA Clayton Park West. Welcome. And welcome.
Good afternoon, Keith Irving, MLA King South.
I'm the MLA for Hammonds Plains Lucasville, Ben Jessam.
Hi, I'm the MLA for Hants East, Margaret Miller.
Pleasure to have you here. My name is Carla McFarlane, and I am the MLA for Pictou West.
And I'm Barbara Adams. I'm the MLA for Cole Harbour Eastern Passage.
Hi, I'm Sue LeBlanc, MLA for Dartmouth North.
Hi, Tammy Martin, MLA for Cape Breton Centre.
And we have our Ledge Council, Mr. Gordon Webb, and Judy Kavanaugh, who is our clerk for the meeting. We will now turn it over to Ms. Hazelton for introduction of her group and also for opening remarks. Ms. Hazelton.
Good afternoon, and thanks for having us. My name is Janet Hazelton, and I'm the president of the Nova Scotia Nurses Union. And we represent around 7,000 nurses in the province, in 38 different hospitals, many of the long-term care facilities, and all the nurses in VON. So we have sort of a wide range of nurses that we represent, RNs, LPNs, and NPs as well. And with me is Paul Curry. He works in the research arm of our organization, and he did a lot of the research and the focus groups with our nurses, with the communities, with various stakeholders throughout the system. And when the report was completed, it was circulated to nurse leaders, Department of Health, many people to take a look to see, you know, are we on the mark or not? So there was a fair bit of work went into this report. Working with him was Justin Hiltz, who also works for the Nova Scotia Nurses Union, but he is on vacation today. And Ashley Buckles, she is a current registered nurse that works in this province, but was taking her PhD, Master's. And we hired her last summer to help Paul and Justin complete some of this work. And also with me is Colleen Logan, and she is the communications person that works for our organization and does all the work around getting the book together, the pictures, the social media, all of those. The ad, we had an ad that we also made to go along with the book to inform Nova Scotians that the important role of nurses within the primary healthcare system. So that's our team. For the most part, I'll be answering the questions unless they are specific in nature, like, is this statistically significant, or how many people, and Paul will take those questions. But for the most part, I'll be talking about the recommendations. We believe the recommendations in this report are doable. Some of them are doable easily and can be done quickly. Others, you know, we'll need to talk to stakeholders. We'll need to bring together stakeholders that are involved, and what do we do to make this happen. So I'll start with a little introduction, and then we'll talk about any of the recommendations that you guys want to dig deep into and ask us if you have questions or concerns or how we see this happening. So we all know that Nova Scotians are concerned about the healthcare system in this province. They have concerns about access to primary health care. They have concerns about whether or not they have a doc, how long they're waiting in our emerge department. We have a focus in this province of keeping people in their homes as long as possible. And how do they access care when they're home? How do they access care when they're sent home? If some of the reasons they can't be sent home is because they require care that they need to access, and how can we do that better than what we're currently doing today? We've heard from our nurses as well their frustration in an emerge department, knowing that people are waiting too long, knowing that a lot of the people that are in that wait room just require primary health care. They don't require emergency care, but they don't have a choice because they have a urinary tract infection and it's a Saturday. Whether they have a GP or don't have a GP on a Saturday with a urinary tract infection, somebody needs to look at these people and prescribe medication and let them go on their weekend. But that's not possible in many cases in this province. And so we wanted to talk to Nova Scotians and nurses about that. So 18 months ago, the Nurses Union, the board of directors that run our organization, who are all practicing nurses in this province, directed me and our staff, we want to do something that's looked at as positive. We want to be part of the solution. Nurses are the biggest group of workers in the healthcare system in this province, and our board said, you know what, we really think we have solutions. We know our nurses have the solutions, and we want you to go and talk to our nurses about that. And that's what precipitated this work. We all know that we need research in order to get anything done of any kind of measure, that research has to be done. People want to see. And I think if any of you have read this book, the amount of research in it is phenomenal. We all say that we have the sickest, oldest residents in this province. This research shows that we do. We have the sickest, oldest, Nova Scotians are the sickest, oldest people in the country. And they have the most chronic illness, diabetes, heart failure, obesity, those kinds of issues. Again, not proudly, but we're ranking #1. And so that research tells us that most of those issues can be dealt with through primary health care. Diabetes can be managed with a primary health care person, whether it's a nurse practitioner, whether it's a registered nurse, a licensed practical nurse, or a GP. All of those healthcare workers are able to talk to, treat, ask people, teach people. Like most of our chronic illness is just teaching people proper diet, how to control their insulin, how insulin and exercise, how they go together or not, what they should and shouldn't eat. Many of our diabetic just don't know that this is not good for you or that has too much sugar. Like, who knows that half a bottle of ketchup is full of sugar? People don't understand that. And so a lot of it is just education to know that I shouldn't be using ketchup because you don't think that ketchup is full of sugar. So those are the kinds of things that our nurses know, and they know that that some of the patients they're seeing come through our emerge department ought not to be there. Asthma is another perfect example. Many of our emerge departments are children with asthma attacks. We need to teach their parents the proper care on how to avoid an asthma attack. What do we do when their child has an asthma attack? Taking them in the shower, filling the shower up with steam, that often will subside. But that requires our nurses and healthcare professionals to have the time to talk and teach parents, to teach the children, to teach Nova Scotians how to look after themselves properly. So far, I'm really sticking to the script so well. I don't think I've said one thing that's in the script. So our research, or the research, advocates for reform along 4 main themes. And the first one is system dysfunction. In order to build a better healthcare system, we need to build it on the foundations of a robust primary healthcare sector. And we know this. We know that people need primary healthcare. And primary healthcare does not necessarily mean that everyone has to have...
Order.
Oh, sorry.
There are no photographs allowed while we're in session, except for the media, and you must be sitting down and not hanging over the railings. Okay. Sorry about that interruption. We have some tourists in our gallery. Ms. Hazelton.
So we believe we need to break down the barriers that impede effective health care. In particular, we need to ensure that professionals in home care, hospitals, and collaborative practices are able to access and share information via the same electronic charts for one person, one record. And we're working on one person, one record in this province. But one of the things that was identified is that's great if we're going from hospital to hospital, but what and how we're going to use that one person, one record in the community so that our VON nurses will be able to look at the one person, one record to see what happened to them while they're in the hospital, what care did they require, and what's the post-op or the post-discharge care. That needs to be at the fingertips of our community nurses, and it isn't right now, and that's something that needs to happen. The other thing is system design. We think, and our nurses think, our nurses and other healthcare workers are out there every single day, working to the best of their ability to provide the best care they can. The unfortunate piece of it is that there's so much negativity around the work that they do. And many of you, are probably in the same, you're working very hard to represent Nova Scotians, and oftentimes people are very critical of the work you do. And talk about how in a negative way. Well, that's the same feelings that our nurses get. They understand there's problems and issues in the system, but they want to be part of the problem, and they want their work to be recognized as valuable and not, that I'm waiting 5 hours and emerge, and that's not the nurse's issue. But so our nurses are very proud, and I think that's the point I'm trying to make, that we need to stop focusing on the negative and start looking at what can we do in a positive way to reassure Nova Scotians that our healthcare system has problems, there's no doubt, but it's still a good system. If someone was to have a heart attack or chest pain right here today, they could be taken to the QE2, have a stent put in, have their x-ray done, and within hours. Do we have issues around wait times for cataracts and orthopedic? Absolutely. And we need to talk about how we fix them. But we also need to recognize that the people working in the system are working very hard. And when there is a true emergency, more often than not, people are getting seen to appropriately. And that's the reason why we got 6 and 7 and 8 and 10-hour waits in lots of our emergency departments. Because behind the scenes, there's someone with a car accident or a heart attack or an amputation that are being treated to, and all our nurses and physicians are busy dealing with that emergent patient. And we can't go out and advertise that to the wait room. Sorry, we have a really bad MVA, and we're not permitted to have those kinds of conversations with the patients in the wait room, but that's exactly what's happening. And so some of the recommendations deal with that. I'll stop talking so you can ask questions if you like. Because if anyone that knows me, I can talk for 3 hours.
No, please continue. Ms. Hazelton, you may continue.
So we came up with the recommendations that are in the book before you, and I know the book is long. I get it. I'm not one to pay attention to a lot of detail, but I honestly did read it twice, maybe no more than twice. They read it 8, 9, 10 times. But it really, truly is. If you haven't read it, it's worth the read if healthcare interests you in this province, because the data in this is amazing. And the ideas and the recommendations, they are coming from nurses, nurse practitioners, the public. That's where these recommendations are coming from. We just coalesced it all. And all of the data around our health or not health population of Nova Scotians is all in there with the data. It is an extremely important read in my view, and it really captures a lot of the issues that we have around healthcare in this province with our many, many, many recommendations on how we believe these can be fixed. Some are, and you have it. So that starts on page, this document here has all of the recommendations. So what I think some of the easy wins, when I started nursing in 1984, if you wanted to see a nurse in your home, you called up VON, made an appointment, and the nurse came to your home. That's it. Now, it's it's a cumbersome process, and you can't just do it. You have to be approved. You have to go through an approval process. There has to be someone assigned. There has to be a risk assessment. And I'm not saying none of these things are important, but some of them just take too long and make us not nimble. So if I have a 92-year-old mom, and I'm looking at her ankles and say, they're looking a little swollen. I wonder if something's going on there. Our view is you should be able to call up the VON and have a nurse drop by to say, yeah, it looks like you're starting to have a little edema there, and we need to call your doc, and maybe we need to look at your Lasix. Because what happens now is people wait 3-4 days until they're in congestive heart failure, when a simple little visit by a nurse could have prevented that. Not only visit to emerge, admission to hospital, not only that, but what happened to that 92-year-old mom. You know, we had a system where the VON nurses would go in and do INRs. They would take blood, they would look at, an INR is clotting for our mostly seniors on
Coumadin.
Yeah, on warfarin. And so what happens is they have to have a certain level, blood level. So they used to go in, prick a finger, just like a glucometer, look at the reading. The VON nurses had a range that they could say, Mrs. McDonald, take a half a pill, or take a pill and a half, or don't take a pill, or whatever, depending on the reading. If it was too low or too high, they'd call the GP looking after whomever and ask, and they'd get an order, right? Now, the same person has to go to a hospital, get their blood drawn, go back home, all requiring probably a family member, wait until the lab reads it, faxes it to the GP reads it, calls the patient, and tells them what to do. Like, it's taken a whole day what used to take 10 minutes. And so, again, that makes no sense. So those are some of the easy wins that we think. Nurse practitioners in emerge. Like, that makes perfect sense to us. So we could have 2 streams of patients in our emerge departments. They're called 4s and 5s. So 4s and 5s would be your earaches, your urinary tract infections, your pneumonias, maybe a broken bone. Not emergency, but urgent, but not emergency. We could have nurse practitioners in the next hallway seeing all those patients, ordering the x-ray, seeing it's pneumonia, ordering the antibiotic, discharging them home. Easy. Those things could happen. Those things could happen. As a matter of fact, in Digby, they just hired a nurse practitioner in emerge, and originally they felt that the nurse practitioner wouldn't be able to work unless there was a doc there. But there's recent changes that you people voted on through the College of Registered Nurses that really allows the nurse practitioners. They were always able to practice autonomously. However, there was phrases in the Act that gave people the impression that they had to be in a collaborative practice. That's not so anymore. They can act independently. They always could, but with that word collaborative taken out, the notion is gone that there has to be collaboration. Nurses, all nurses, have to collaborate. That we don't have a choice. If I feel as a nurse that I'm over my head on whatever it is, I'm required under my license to collaborate with a physician, a nurse practitioner, because I'm a registered nurse, I'm not a nurse practitioner. The same applies to nurse practitioners. The same applies to GPs. They have to collaborate with a specialist if they can't deal with, I don't know, a complicated chest pain. They probably will consult a cardiologist. So everyone in the healthcare system is required to collaborate. So, you know, a lot of the stuff that we're hearing in the press about nurse practitioners is just not right. Nurse practitioners can see people independent. They have their own practices. They have their own client base. They look after Nova Scotians every day in this province. However, we believe that they could be utilized better, like in emerge. We believe that they should be in long-term care so that they can get under the covers of the numerous medications that some of our seniors are on in long-term care. Instead of sending our long-term care resident out to the hospital, if there was a nurse practitioner assigned to it wouldn't be one long-term care facility, it would be a whole host of long-term care. Like in Truro, I think there's 5. So one nurse practitioner could do all 5. And then the nurses could call up and say, could someone come and look at Mr. McDonald? I think he's starting to get pneumonia. She could come, she could assess, and she could put the resident on antibiotics. No, we put them on in an ambulance, take them to emerge, they wait, they may be admitted, they may not be admitted, and then they're sent back home. So that's congesting our emerge department, but more importantly, there was no need of that resident necessarily going to the emerge department. So there's another area we think nurse practitioners are of value. A third area is our VON nurses tell us they have lots of patients that started in their care, let's say 6 months ago, 8 months ago, and they had to get dressing changes or whatever it is. And in the meantime, their doc retired or moved or is gone. Well, now they don't have orders. They have to discharge the patient from their service because they have to have orders from somebody to continue with the dressings. There's another perfect role for our nurse practitioners. You know, we're starting RN prescribing soon, I think January-ish, which is another huge step forward for nurses. So registered nurses in specific areas, I'm going to pick one because I don't think it's fully sourced on exactly where they're going to go. I think some in mental health and some, but I'm not sure, but I'll pick one, emerge. You know, someone comes in, I was an emerge nurse, someone comes in with a urinary tract infection, we take the urine, we send it to the lab, it comes back, we can read the piece of paper that says they have urinary tract infection. Like, we can see that. We are going to be able to, RNs, write a prescription for antibiotics. Because it says, this is the infection, this is the antibiotic of choice. So again, it's a good utilization of our nurses so they can discharge the patient home. Because now what we do is we wait and we wait and we wait until our emerge physician, who was so busy seeing emergencies, then he has to come out and see a whole bunch of these patients like urinary tract infections that could be home. You know, so we really believe that's a better utilization of our system. And it's not just, we have emerge nurses too that are better in trauma, and maybe others could be doing this other piece of work. I don't know, does anyone have any questions? Yeah, I can see. Look at the. I am supposed to stop at some point, aren't I?
If you're finished your opening remarks, we will start questions.
Sure. Yeah.
Okay. So thank you for your opening remarks. Please wait to be acknowledged so that the microphones can be turned on when you do your response. And we will start with the PC Caucus for 20 minutes. Ms. McFarland.
Thank you very much, Madam Chair. Thank you so very much for your delivery on this report and for being here today. And it's also a great opportunity for us to extend a shout out to all levels of the nursing profession in Nova Scotia. Where would we be without them? I think we're, as a province, very grateful for the work that they do and the commitment, in particularly during such difficult times when we know there are many gaps in our healthcare system. So looking at, I believe the report came out on May 7th. And so we've had about a month and a half. And I think a lot of Nova Scotians, and I know myself, we look at the Department of Health and Wellness and NSHA, and we wonder sometimes if there has been, you know, opportunities missed where some of these recommendations could have immediately and hopefully effectively been implemented to improve, you know, patient care. So if you could elaborate on the conversations that have happened between yourself and the Nova Scotia Health Authority and the Department of Health and Wellness, has any recommendations been considered or implemented to date? Any formal process between yourself and those two bodies?
So, Ms. Hazelton.
Oh yeah, that's what you meant by wait to be acknowledged.
Yes.
Yes, we're are fortunate in this province to still have a provincial nursing network. Many of the provinces across this country have eliminated that group of individuals. So the provincial nursing network is a group of nurse leaders from across the both unions, plus St. FX, Dalhousie, all leaders from there, plus the Department of Health and Wellness, plus several nurse leaders from the Nova Scotia Health Authority, also nurse leaders from long-term care and community care. So we consulted with that group prior to even publishing this. And some of the recommendations, like RN prescribing, is happening. It's happening and it's going to happen. We've been talking about it for a while, for sure, because they've been doing it in New Brunswick for quite a while. And so we've taken it to the table, they've done the research, they've developed a program, and through monies, through the Provincial Nursing Network, nurses are going to be supported to take that, I believe, starting in January. So some of these recommendations made it to the book, but we've been working on with that group of nurse leaders from across the province. So the other ones that are more of a challenge, certainly the nurse practitioner in long-term care, that came out in our Broken Homes report. And we are still waiting for that. There's a couple, maybe 3, if I'm not mistaken, that are in long-term care. I think Cumberland County, Cape Breton, and at Northwood. But not quick enough and not soon enough, in our view, but it is happening. And the other exciting thing that this report requires us to have a significant number of nurse practitioners in the system. We have gone from about 30 to almost 200. So there has been significant investment in the nurse practitioners. And so what I like about the Provincial Nursing Network is it's not about politics. It's about nurse leaders coming together to get things done. So one of the programs is the nurse practitioner. If a registered nurse, for example, I don't know if you know this, let's say Inverness is one, the health authority is to identify for the Department of Health, where do we have gaps in care? And let's say Inverness, Inverness has an issue. So what we've worked on and has been successful is a registered nurse working in Inverness, in the hospital in Inverness. If she gets into the NP program at Dal, will continue her full salary and benefits the entire time she's studying to become a nurse practitioner. But the hook is she has to go back to Inverness and work there for 5 years. But in our view, she's already proven, because she lives in Inverness, she has a family in Inverness, she can't afford to go be an MP because she can't give up her full-time job for 2 years to go study. So those were initiatives that came out of the Provincial Nursing Network.
Ms. McFarland.
So thank you so much for that response. So at the end of the day, and I mean, I know that there were discussions prior to this report coming out with regards to RNs being able to prescribe. So I know it's one of the recommendations, but we are aware that certainly those were conversations happening before this report came out. So is it fair to say at this point, just a sort of a yes/no simple answer, that none of the 35 recommendations to this today have been considered for being implemented within, let's say, over the summer or any time quickly?
Yes. Ms. Hazelton.
Oh, I'm going to get it one of these times. Can you tell what a kid I was in class? Yes, we're starting to work with the VON about what can their nurses do and what are the issues that we're working with VON, the employer, about the recommendations that involve them and what obstacles they see that we need to get around or through in order to make that work.
Ms. McFarland.
Great. Okay, thank you very much. Because I look at some of these recommendations, there's a lot of good recommendations, but there's a lot of them that can actually be implemented fairly quickly. And it's somewhat disappointing to see that there's, my understanding anyway, that none of them have been implemented at this point. And congratulations, yes, on, in the new year. Again, that is something that was being discussed prior to this report, though. looking at, I want to go to page 74 in the report, and we know that it's indicated that 45% of emergency department nurses feel that the majority or most of, the majority of patients seen in emergency departments, present conditions that are, made worse possibly by insufficient primary health care in this province, right? So looking at your chart that you provided, out of that 45%, though, 44% of the emergency department were RN or LPN that you actually collaborated with to get this information. Was there any collaboration with the other levels of healthcare, like primary healthcare, home care? How do they feel about this?
Ms. Hazelton.
So the only people we discussed, the healthcare workers, were nurses, obviously, because those are the only individuals we have access to. We have the ability to contact our nurses directly. And we did hear frustration from our community nurses and our long-term care nurses and others that, they don't believe that people necessarily had to go to an emerge department. They could have dealt with it had they the ability. Is that answering your question?
Ms. McFarland.
Thank you very much. So again, just for clarification for everyone, so you were able to conduct and work with nurses in your union, but not beyond. Is that what you're saying? Okay.
Ms. Hazelton.
Yeah, except for the nurse practitioner community.
Ms. McFarland.
Thank you. Thank you very much. Okay, that clarifies that. Thank you. So if we can just go the overall picture for nurses in this province of all levels, since let's just say, so we've been in 6 years, let's say the last 5 years of this Liberal government and perhaps since amalgamation, can you perhaps elaborate what is the impact and the stress on nurses with regards to Nova Scotians not receiving the proper basic and having access to primary health care?
Ms. Hazelton.
So I think one of the obvious stressors, and we speak about that a fair bit as well, is violence. We have an unacceptable level of violence in our healthcare system, and we believe that a lot of it is because we're in a McDonald's society where, people come to emerge and they expect to be back home within an hour. Well, that's just not happening. They want home care, and it's going to take 3 months or whatever in certain areas of the province. So we think that those kinds of issues are creating an atmosphere in our healthcare facilities of aggression towards the nurses. So we've had incidents where nurses have gone to the emerge department or work in the emerge department, have gone out and said, we're not going to be able to see Johnny, Joey, little Susie for 4 hours, and the parent gets irate. And we're lucky if we're only getting verbally abused. So I believe that a lot of it's never acceptable. It's not part of our job. It should never be part of our job. But I think a lot of it is becoming worse because of the sometimes long waits for care.
Ms. McFarland.
I would agree. I would agree on that. And my concern is what type of impact do you see and hear and witness as in the amount of stress, leave, and sick time that nurses in emergency departments are taking?
Ms. Hazelton.
So it's not just nurses in emerge departments. It's the nursing population is mostly in the community, actually. The amount of sick time is higher than pretty much any other type of worker in the province. But more importantly, the amount of violence is higher than a police officer. It's higher than, a prison guard. One would think that a police officer would be the end of violence more than a nurse, and that's just not so. So the workers' compensation claims within the healthcare system is unacceptably high. Nurses and others are getting not just violence, getting hurt at work more than any other profession in the province. So that's back strain, all of those kinds of soft tissue injuries. You know, we shouldn't have to go to work and come home tired, but we should come home safe. And that's just not happening. And you know, it's not just Nova Scotia, obviously it's across the country, but there's an unacceptable high level of violence and injury within the nursing profession.
Ms. McFarland.
Would you say that that has increased in the last 5 years?
Ms. Hazelton.
Yes, definitely.
Ms.
And
McFarland.
thank you, Madam Chair. So what, out of your recommendations, is there any one particular recommendation that could actually be implemented right now to somewhat alleviate those concerns?
Ms. Hazelton.
Well, the wait times emerge. You know, we are recommending a nurse practitioner. And what we're saying about that is, you know, the catch-22 of it is most of our nurse practitioners are working, they have a big practice, they've got, I don't know, hundreds of people they're seeing, and so if they move there to the emerge department, they're leaving hundreds of patients without, so that's easy. Most of them are employees of the health authority, so let's offer them an extra 4 hours on a Saturday, an extra shift, and at least try it. And then we think, and we know that like our busiest emerge, one of our busiest is Colchester and another one is Cape Breton. And the nurses in Cape Breton are saying, because we asked, do you think nurse practitioners working in this department would help? And yes, definitely, we need it. So my thing is just let's do it.
Ms. McFarland.
Thank you very much. I know a number of nurse practitioners across this province right now that can't find work. Why do you think that is? Like, we need them. So what is the proverbial brick wall from allowing them to be able to work in the profession that Nova Scotians absolutely need right now?
Ms. Hazelton.
I have no idea who these people are. Just tell them to send me an email. I'm serious when I say that because you know, my understanding is every nurse practitioner that wants work in this province has work. And if that's not accurate, because one of the barriers is just what I mentioned. Now, not every nurse practitioner will be able to work in Emerge, but they are able to look after the 4s and 5s in Emerge, for sure. If they're family practice nurses, they can, not family nurse practitioners, they can work in Emerge seeing all of those clients, for sure.
Ms. McFarland.
So there's a recommendation to have a nurse practitioner in every emergency department in this province, but that's not fulfilled. That's one of your recommendations. So you're saying right now we have a shortage of nurse practitioners. So if that's the case, what do you recommend this government to do to change that?
Ms. Hazelton.
So my understanding is there is a shortage, and if I understood that there's no nurse practitioners to spare, if that's inaccurate, then that's important knowledge for me, for sure. And if not, we have to look at how many are we graduating? Is that enough? Are we graduating them in the right volume at the right time? Do we need to periodically bring them out at different times? You know, to go from an RN to an NP is not, especially if you're an RN with loads of experience, it's not that big a leap, right? It costs money and it costs time. The challenge is, if I'm an RN living in Truro with 3 children and I'm making whatever I'm making as an RN, I can't afford to give up my job to go to school for 2 years. It's just, and if I do it part-time, it's going to take me 5 years. And so by the time I'm finished 5 years, is it really worth it? So, like, you know, it's very difficult to study and work at the same time. It's, you know, what? Oh, yeah. So, yes, our recommendation, good, 33 is increase the 200 to 500. I think we can employ every single nurse practitioner, and we should be.
Ms. McFarland.
Great. Thank you so much for that answer. I'm concerned about the one patient, one record. I think a lot of Nova Scotians are, as we look at different breaches that are happening in our most vulnerable and personal information. I think I used the expression the other day. There's lots of information we can't find out from this government, but a lot of this personal, vulnerable information is just blowing in the wind. And when you keep mentioning, I've heard you now several times mention the word collaborative. And so it's very concerning to me to make sure that when this, is implemented, that everyone has been consulted. All allied healthcare professionals be consulted and communicated with. So could you elaborate on the discussions that you have had in moving forward to ensure that you play a role and a part in knowing that how this will be rolled out will be sufficient and effective and with regards to your people that you represent?
Ms. Hazelton.
So, to date, I've been present for a meeting where the process on how they're going to go about it, how they're going to RFP it, what it's going to look like, what it intends to do, the chart. That's the extent. But we have electronic charting now in most, but they just don't talk to each other. So the chart from Colchester Hospital can't communicate if I'm going to the QE2. They just can't. So it's a very cumbersome the way it is now. But, people, other provinces have it, and hopefully the people that are designing this are talking or collaborating with what were your pitfalls. I also sit on the Workers' Compensation Board, and we're just going through a big transformation and going into electronic, not charts, but electronic files for injured workers in this province. And I think, and I've suggested, we just went live 1st of June, and it's the same kind of issues, right? It's injured workers' personal information and personal health care. And so, I've suggested to the individuals within the Department of Health that are looking after this, that they need to pair with workers' comp, because I've been on the subcommittee, so I'm intimately involved in all of the issues that we've been going through around transforming workers' comp. So we've spent a lot of money at workers' comp to do this, and we've had a lot of expertise on it. So my suggestion at that meeting was that they ought to team up with the folks at workers' comp that are now, in my view, experts on confidentiality and privacy and all those kinds of issues.
Ms. McFarland, for less than 30 seconds.
Just a quick question. When you say you had one meeting, just quickly, who was it that you met with?
Ms. Hazelton.
I can't recall. It was two individuals, one from the IWK and one from the Department of Health, that, in my understanding, they're the ones leading the one patient, one file. But on that issue, though...
Order. Time has elapsed for the PC Caucus. We'll move it over to the NDP Caucus. Ms. Martin for 20 minutes.
Thank you, and thank you for being here. First of all, there's a tremendous amount of material here. We only have a short amount of time, so I'm just going to try to get right to the focus that we want to shine some light on. We'd like to thank the NSNU, however, for the many great ideas that have been articulated, and it certainly gives us lots to consider on what our healthcare system could look like if we paid closer attention to the people who deliver it and who should be organizing it. That being said, I'd like to focus on staffing in the next few minutes. The report notes that management practices of not backfilling vacation and sick time are, in the author's words, and I quote, an ongoing problem. The author goes on to say that working with reduced staffing levels jeopardizes the quality of patient care while overburdening the nursing workforce. So, two parts. Would it be fair to say that many nurses are suffering from burnout as a direct result of this practice? And two, do you believe that these practices are contributing to nurses leaving and or dropping down to fewer hours?
Ms. Hazelton.
That's an easy answer. Yes. It's very difficult to work fully staffed. It's almost impossible to work if you don't have like, as I described to some people when it comes to being a nurse, As the president of the Nurses Union, I can wake up this morning not feeling all that great, but I'll manage. You know, I'll get in my car, I'll come and I'll do my job and I'll go home and maybe go right to bed with a couple Tylenol. When you wake up as a nurse and you're about to go in a 12-hour shift, you have to be at the top of your game. You can't, like, I'll drag myself through the day. You can't drag yourself through the day as a nurse. It's just not possible. You have too much responsibility and it's just too difficult. It's a very difficult job physically and emotionally as it is. So that's why, part of the reason why our sick time is so high. Because we don't work in offices. We work shift work. We work every other weekend. We work 12-hour shifts. We have to stay past 12-hour shifts, sometimes 16 hours, sometimes longer. It's difficult. And so when you get up and if you don't know that you're not going to be expected to stay 16 hours, so I wake up, I'm not feeling well, I know I'm off in 8 hours. If I wake up and I'm not feeling well, I don't know for sure even that I'm going to be off in 12. So I agree. I mean, nurses are reducing their status because they're burnt out, just as you worded it, for sure.
Ms. Martin.
Thank you. And as the mother of an emergency room nurse whose daughter just worked 17 hours, I completely agree. Because you go assuming you're going to come home in 12 and 14 and 16 and then 17 and then you finally get to go home. So, but what justification do you think management offers for this? Is it that nobody's available? Like, why aren't they filling or calling in people when somebody's off sick? Is it that nobody's available or that nobody is willing to come in and do the work?
Ms. Hazelton.
Both. So in some situations, especially in rural Nova Scotia, no one's available. There just isn't. You know, when I started nursing in 1984, it took, I think I was a year or more working casual before I got a job. We don't have casuals. There's no such, like, I'm not saying there's no casuals, but there's very, very few casuals. So we're not able to, you know, we don't get vacation often because there's no one to work for us. So I want Saturday off, well, too bad. Like, unless there's someone to work for me, I can't have Saturday off. Where when I started, there was people like me working casual that said, I'll work Saturday, sure. You know, so, you know, there's a shortage, but also nurses just don't want to work any more than full time, and they shouldn't have to.
Ms. Martin.
Thank you. And again, I completely agree. We've heard, though, from many healthcare workers, many nurses, and that the NSHA cannot find enough nurses to fill the shifts. As you know, we're closing lots of hospitals, especially Glace Bay and North Sydney, because we don't have enough nurses to fill the shifts. From your experience on the ground, is there a nursing shortage in Nova Scotia?
Ms. Hazelton.
There's registered nurses. We have a challenge. We're doing a bit better. I think we're hiring, I'm not hiring them, but there's about 600 new nurses that are going to be entering our system in the fall, like now and into the fall, which is good. But we definitely have a shortage in pockets. You know, and more significant in some pockets than other. Cumberland, for example, Cumberland County, they have a huge challenge recruiting and retaining nurses to work in that hospital. Others, it's not as much as an issue. The problem with some new grads, and I'm not saying there's a problem, but it's an issue, is they all want to work, potentially in Halifax, at the IWK or the QE2, right? Because this is where they're young, and this is where, you know, this is the city. They don't want to work necessarily in Port Hawkesbury or Pugwash or Powersboro or Advocate. So there are areas in the province that are increasingly challenged. One of the good things that's happened, and that's not just in the last, it's been several years, was the CBU. Extending the nursing program there was a brilliant move because most of the nurses that graduate from there stay and work there, which is awesome because we used to have a huge issue in Cape Breton as well. But we do have, to say we don't have a shortage, I think is inaccurate.
Ms. Martin.
Thank you. Sadly, there's a nurse that I know, though, that's travel nursing right now because she can't get a job. She can't get a permanent job in Cape Breton. So it kind of flies in the face of, yeah, exactly. That's what I said when I heard that. Is this shortage putting people at risk, staff, patients?
Ms. Hazelton.
Anytime you work short-staffed, there is a risk. There's always a risk. You know, if any profession, if you know, if you're not putting enough teachers in the classroom and one teacher is expected to look after 2 classes, that's a risk. So, yes, but there are things, and one of the things that through this PNN that I've been talking about, one of the programs, which is, I think, going to be, it's like the NP to RN. They're going to do it with LPN to RN. So we have an accelerated program at St. FX that LPN can apply for. But again, she has the same problem. How is she going to leave her family and her children to quit her job and go to school? So they're going to start with 9 LPN to RNs. Through the PNN, again, this all comes through PNN, these ideas, and so that might help because they're also going to look for hard to recruit, like Canso, and you know that Canso Hospital had to close for the night shift because of a lack of RNs, and it was a difficult day for the people in Canso. I was there. It was very difficult, very emotional. That was the first time that facility closed in 60 some odd years, and it's because of a lack of RNs, not because of a lack of physicians.
Ms. Martin.
Thank you. In 2015, the Department of Health and Wellness did a paper, a report on the nursing strategy, and I'll table that document then and now, and it showed that the RN gap in Nova Scotia would continue to grow to a shortage of more than 900 FTEs by 2024 if Nova Scotia did not put into place a number of measures, including reducing turnover to national rates, hiring 90% of new grads, increasing RN productivity by 1% per year, shifting 5% more RNs to full-time hours. So 900 RNs is a lot, and as of December 2018, we have 5,100 practicing RNs and 1,516 practicing LPNs, FTEs. Were you aware of this review, and how has that changed, or what is the extent that we're still facing that challenge and it will continue to grow by 2024?
Ms. Hazelton.
Yeah, I was aware of the review. I was part of it. So I've been sitting on PNN since I've been president. So since 2002, I've been sitting on the Provincial Nursing Network. And since then, the seats have increased. The seats in universities have increased. It's a 4-year degree program, right? So it takes a while to see, and I think we're just starting to see right now the fruits of those kinds of decisions to increase the seats in our both at St. FX and Dalhousie. The worry I have, and what I will continue, is just because we're seeing the results, we can't take our foot off the gas. We need to continue with those seats, because now, I mean, I'm happy to say, we're having more significant issues with maternity leaves than we are with retirements, which is awesome. As long as all those children become nurses, we're golden. But so we have to make sure whomever is in government, they do not touch those funds that have been earmarked for increased seats in NPs, increased seats for the RN program at St. FX, CBU, and Dal. We're starting to see a bit of light. This is the first summer that people are getting some vacation, so it's not there yet, but it's 600 new grads this year. That's pretty good. I think the health authority, don't quote me, but it's something like 400 or 350 job offers out. That's great, but it's still not enough.
Ms. Martin.
Thank you. So to that end, will that cover the vacancies? Like, do we know how many current vacancies or ongoing vacancies are in under the NSHA or within the province? Because you're right, 350 offers is wonderful, but what will it take to get us up to a balance zero?
Ms. Hazelton.
I'm told somewhere around 500. But again, it's so hard to track this, you know, because Nurse A goes on maternity leave, Nurse B takes her job, and she leaves a job back here. And so it's like us trying to figure it out as a union, it's very, very difficult, you know, because, and then all of a sudden is where did it go? We're not sure of that sometimes. So I do wish we had better data, but again, through PNN, my understanding is that they have an individual now that's going to look at the numbers and do some extensive calculations for us to take a look at, you know, where are the vacancies, because we're only talking about the health authority here. We're not talking about the IWK, we're not talking about long-term care, which is huge challenges, and VON is starting to get challenged as well to recruit into their positions. So many of these recommendations need to have full complements of staff in order to make it be. You know, we can't add work to the VON if we have vacancies there that aren't filled. So we have to make sure everything is marching along at the same time.
Ms. Martin.
Thank you. Do you know what our current RN turnover rate is in Nova Scotia? In 2016, statistics had the outflow rate of 8.1%.
Ms. Hazelton.
Yeah, I knew it was 8.1, but you're asking right now what it is. I don't. We get that from Kai High, just like you got it from Kai High. We don't get any more current information than that. But I think again, Department of Health. It's Adrian, isn't it? Adrian has been hired by the Department of Health under the Provincial Nursing Network to look at and dig deep about the not just nurses, but he's doing nursing, but other healthcare professionals, and what are the vacancy rates, and what do we need, and how many do we need, and so I understand he's working on that now.
Ms. Martin.
Thank you. The report talks a lot about recruitment and retention, which is a huge issue. What factors do you think that you could identify that would improve our rates of recruitment and retention? Like, for example, in New Brunswick, an LPN is paid $30 an hour to start, and in Nova Scotia, we are the lowest paid. So, you know, aside, well, salary being one, because of course everybody wants to make a good wage or a comparable wage, but we're the lowest in the country. So, what can this government do to, you know, recruit and retain the hundreds of healthcare providers we need?
Ms. Hazelton.
I think one of the biggest challenges, other than compensation, is work-life balance. You know, that's huge. You know, nurses have to get their vacation in the summer, and to be told, you know, you're not going to your son or daughter's rehearsal party because we can't replace you is devastating. And it happens. It happens. Or no, you can't have that surgery because we can't replace you. And that's happening. So the work-life balance, we have to get better at. And sometimes tough decisions are going to have to be made. Like, if you can't staff your ICU, wherever your ICU is, if you can't staff it, then maybe we need to do something about and nobody wants to hear that. Nobody wants to hear maybe we have to reduce from 10 beds to 8 beds so that we can give a couple of people some vacation. But that's reality. And I think the big thing is Nova Scotians have to understand the fixes for some of this is going to cost money. And the only way we can get money is through taxes. And that's the same for long-term care. That's the same, you know, if we're going to, and I'm getting off, it's not this, if we're going to want and respect our seniors in long-term care, then we're going to have to figure out how to pay for it, because the staffing in long-term care is worse than it is in acute care. So, you know, work-life balance is hugely important to nurses. You know, most of them, 97% or so, are female. So 90% of them are moms, right? And they have children, and they have challenges, and they have kids graduating, and they have all kinds of things happening. And they have to be able to attend them. It's just not fair that I can't go to my son's graduation. There's no other profession I know of that happens, that I know of.
Ms. Martin.
Thank you. And sadly, I'm going to have to disagree with you there, Janet, because I believe that the surplus that the Liberal government is sitting on is a way to fix the healthcare crisis. Because right now, the government is more concerned with balancing the budget than making the investments we need into healthcare and into nurses and into long-term care. And to that end, I would think that Bill 148 has significantly impeded recruitment and retention for nurses. Would you agree?
Ms. Hazelton.
Sadly, there's Bill 148s all over this country now, unfortunately. I believe that interfering in collective bargaining is wrong. It's just wrong. The whole strike discussion, we don't go on strike. We've had one strike in the history of the nurses union. We try to get solutions at the table, but we're able to negotiate our wages, and we're able to make decisions on our behalf. We don't need to be told. We're professionals. We understand the importance of our role. We understand the significance of withdrawing our service. We get it. We are nurses. We don't want someone in long-term care to die because we're on strike. Absolutely not. And we'd never intend. When I was president, before I was president, 1988 or so, I think it was Bill 68, whenever that was, when we provided services, when we did our essential services, but it wasn't an essential service legislation, we did it as an organization, as a union. Tatamagouche Hospital had the same staff during the strike, or the plan was it'd have the same staff during the strike as it would have before the strike, because we understood that we only have 2 RNs on and 2 LPNs. We're not going down to 1 and 1. We're not doing that. The bigger hospitals, of course, we looked at elective surgeries, and we had a solid plan for when we were going to go on strike that wouldn't jeopardize the health of Nova Scotians, in our view. We had people on call that would come in if there was emergency surgery. We had it all. So we don't believe essential service legislation was necessary or appropriate, and certainly Bill 148 was necessary or appropriate.
Oh, Ms. Martin, sorry.
Thank you, and yes, and I would agree. As a union leader and as a past employee of the NSHA doing staffing and payroll for surgical units, I can tell you that the inability to offer these benefits and services to nurses so that they can have work-life balance, they can have a decent wage, is significant to the ability to be able to properly run a hospital. And I don't believe that there's ever been a strike by any healthcare union that has put the jeopardy of patients or residents in harm's way. And I think it was a disgrace on this government to think that grown professional people could not come to the table and negotiate a free and fair collective agreement. Thank you.
Ms. Hazelton, we're 3 seconds.
Oh, I agree.
Order. We'll now turn it over to the Liberal Caucus for 20 minutes. Mr. Irving.
Thank you very much, Madam Chair, and thank you for our guests here today. I want to, first of all, thank Ms. Hazelton for your work. You've become a great partner for government in us working to improve the system, and your work on the nursing network, and I think that's very important to Nova Scotians and to the province as we work to improve the healthcare system. I do want to also thank you for raising the issue that we do have a good system here. Those are your words, and I want to thank those healthcare professionals, doctors and nurses that are doing the difficult job that they do each and every day, even in the constrained system that we've got that is putting pressures on the healthcare system throughout the country, really. And I want to, go back to looking forward rather than backwards here. Your report, I think, is of extreme value to us. About the potential that nursing will play in solutions for the province. So my first question goes around, I think it's on page 55, you talk about reviewing high-performance healthcare systems and referring to Baxter Axler 2015 that envisions a healthcare system. Now, it doesn't really call upon experiences in other jurisdictions. There's no references to in BC they do this or that. So I'm just wondering if some of the ideas that came here are tried and true, tested ideas from other provinces or jurisdictions beyond Canada, or are these really coming from the ground up in terms of talking to your nurses, or perhaps it's a combination of both? But have you exhausted, I guess, the jurisdictional scan of good practices that we might be able to capture and put into practice here?
Ms. Hazelton.
So the majority, you're right, is from the ground up. It's from talking to our nurses to say, if you could, what would you do? What are the problems and what do you see are the solutions? I also sit, though, as a president of Nurses Union with Canadian Federation of Nurses Unions with my colleagues from across the country. And the CFNU has also produced many really great documents about best practice, about safe staffing, about just-in-time staffing. So, we're fortunate enough that we have the access to the other nurse unions across the country, and we meet very regularly to talk about all of these kinds of issues. And when we hear a good idea, so I'll give you an example. All of the nurse union presidents went to New Zealand a few years ago because they have very advanced safe staffing in their country, and we looked at just-in-time staffing. And so what that means is it's not based on patients and nurses, it's based on the acuity of the patient, and that might mean 3 nurses, or it might mean 1 nurse, or it might mean, and so it's a just-in-time staffing. So right now we have a very sort of rigid kind of this many nurses. One would argue that our patient ratios aren't good enough, but what this staffing model does is it looks at, so there's a board that says, oh look, Emerge is in red, so they're hurting down there, but look, obstetrics is in green. They may have the same number of patients, but the acuity level, based on the nurse's assessment in the obstetric unit, is not as acute, so that the management is able to move people appropriately to say it doesn't, maybe call in staff, or maybe move staff around. So it's called just in time, and they have huddles, and they have, and I believe, Newfoundland is seriously looking at it, and we're having conversations about it. And one patient, one chart, there could be something within that might be able to be used to do the just-in-time. So to answer your question, it's sort of a conglomeration of what we get from our colleagues across the country, along with, but most of it came from our nurses, because often the people at the bedside, the people in the community, the people in long-term care, they're the ones that answer, that have they know how to fix it. Sometimes they just need the tools.
Mr. Irving.
Great, thank you. My next question is with respect to nurses prescribing, and I think you said that's about to start in January. So can you explain to us how that's going to work? I believe you've got some stats here with respect to patients' acceptance of and trusting of nurses to give prescriptions, and I'm just wondering if you could explain to us briefly on how that might work, and Are there limitations? Are you prescribing morphine? Are you prescribing antibiotics? You know, are there limitations on that? How would this work as you see it?
Ms. Hazelton.
So currently, nurses have limitations on the medications they give out, depending on the unit. So for example, I might be able to push morphine in an ICU. I'm the same nurse. I go out to the floor, I'm not able to push morphine because there's not the controls in place on the floor that there is in the ICU. So it's going to be similar to that. Nurses are going to go, I believe the program is through Dalhousie, and it starts in January, not the actual prescribing. And those nurses will be hand-selected by, I don't know the process, but a process. The departments they're going to be working in will be hand-selected by the employer and the committee that's looking at that. So let's say it's eMERGE. I don't know the answer to that yet. And if it's eMERGE, it'll be very prescriptive, and pardon the pun, on what they're allowed to prescribe for what. So they won't be just like, here's your prescription pad, go write prescriptions. It'll be very, very, for UTIs, this. When you see this. You know, very, very organized. And it's all going to be under the auspices of the College of Registered Nurses of Nova Scotia. So that's our regulatory body, and they've approved. So the course was developed. It has to be approved by the college, just like all education does. And that's been approved, and now they're able to start rolling it out. But it will be, so in mental health, they'll have different abilities. I think they're talking about like detox and those kinds of drugs. That nurse will have that ability, but she wouldn't be able to go to eMERGE and write an antibiotic necessarily. So everybody will be specialized within whatever department is decided.
Mr. Irving.
Thank you. That's helpful. Are there any risks in terms of I forgot the term, when two drugs interact with each other? Is that where the level of pharmacist comes in to track that, or are these low-risk prescriptions that we're not as at risk with, I guess?
Ms. Hazelton.
So currently, in our facilities, we have pharmacists who, you know, would identify, but most of them would be low-risk antibiotics. So the biggest risk with an antibiotic is if the patient is allergic to it. And so as long as the nurse has assured herself that there is no allergy, there should be no issue. So it will be, and it will, I can't imagine it'll ever be a controlled substance, like a narcotic. That may be, but like out of the gate, that's not going to be an issue. But Tylenol, like we can't even give Tylenol in eMERGE to a patient. Like we know, there's no, the x-ray's here, there's no break. He's got a strain or a sprain. We're gonna wrap him up. It's 10 o'clock at night. He might need Toradol, which is like high octane aspirin. We're not permitted to give him a Toradol to go home with. So those are the kinds of things I'm imagining that these nurses will be able to do.
Mr. Irving.
I'll sneak one more in before passing it along to my colleague. In terms of the VON nurses and providing more supports in the home by RNs, and you talked about the importance of changing the communications around nurses and their work within the VON that go beyond the one patient, one record, which might contribute to improving the communications and the support for patients in their home. What might that look like, those other forms of communication improvements with respect to VON?
Ms. Hazelton.
So some of the challenges around the VON is I think the biggest challenge is the cumbersome process to get to them. You know, and the other issue that VON nurses have told us quite clearly is that sometimes they're not able to use their own nursing assessment to maybe increase the visits, prolong the visits, stop the visits, change the visits. You know, all of that has an approval process through care coordinators, which, and I'm not trying to be disrespectful to care coordinators, but many of them may or may not be nurses, right? And in our view, and we clearly state it, that is if a registered nurse says, I think Mr. McDonald needs another 4 days of dressing, whatever, then that should never be challenged. The VON nurses are highly, highly skilled nurses. The dressings they do in the home, often, many of the nurses in our acute care facilities aren't doing. Like, they are very, very skilled. We have over 120 or 30 in Metro in Cape Breton that, they work 3 to 11. They take call. Like 3 to 11, they're on call. Well, I'm not sure then the whole, and I was public about the whole paramedic home visits. I was saying, well, we've got 2 nurses on call in Sydney. Like, they're in Sydney. But the problem is the doc that's discharging the patient from the Emerge in Sydney can't get approval for that nurse to go in to see that evening, right? It takes a day or 2. I'm not sure. My view is it shouldn't take any time. They should be able to send the referral off to VON. There's 2 of them on call. They don't have patient assignments. Go see the patient. So, there are some, absolutely, they don't do EKGs in the home. So if that's what the doc wants, that's not going to happen. But there is an underutilization of the VON nurses in this province, without question. They could be doing so much more in the home if they were given the latitude to make those kinds of decisions.
Mr. Irving.
Thank you very much, Ms. Hazel and Mr. Curry, for your report. Very helpful. I'm going to turn it over now to my colleague, Ms. Miller.
Ms. Miller.
Thank you, and thank you for coming in today. I have to confess, I haven't read this all yet, but I am going to this weekend, so we'll be good. But anyway, I want to mention a couple things that were mentioned by the opposition caucus here. But first, I want to say, 2 months ago, I was also in the hospital, and I can't say enough about the great care I had. I didn't see a lot of RNs, but I didn't need to see RNs. I was coming out of surgery and my arm was just broken, so I was okay. But the LPNs I saw did an amazing job, and one was a young lady who was a newcomer to Nova Scotia, and she was an RN in another country, and she was trying to become an RN here, but now she was still at LPN status. So I'm looking forward to at least seeing that she's going to be able to get into some kind of a program that's going to be able to bring her back to her RN status, because she was simply amazing. And the nursing care was wonderful. And I also want to mention about the VON. My dad was able to die at home because of the VON. Thank you. Now, my colleagues here, I found it interesting that the PC caucus has suggested that the government move forward with all your recommendations. I agree, a lot of them are really great, a lot of the recommendations that you had made, but usually the narrative is extreme caution and collaboration. So I found that interesting. And also that the NDP caucus had mentioned about the surplus of government, and that's really funny. We spend up to $900 million a year in interest. $200 million of that alone is from the time of the interest on the money of from the NDP expenditures during their short time, and it doesn't feed, clothe, or provide health care to anybody. And I'd love to see that $200 million back in the system again. We would certainly be able to use that. So, and I have to agree about your McDonald's expectation. I think we're dealing with the same thing in our constituency offices, and I've even had to, unfortunately, put up a sign in my own office that said, if people are going to come in and be verbally or physically abusive, we won't help them. And I know nurses can't do that, but I mean, we had to take drastic action because some people had the expectations that we can move the world, and oftentimes we can't. So, my question, finally, gave you a little bit of a break here. We have the new Nursing Act in the province. I think that is a great act. And how do you see this supporting the implementation of some of the recommendations of your report, particularly as it relates to moving some of the barriers to optimal scope of practice?
Ms. Hazelton.
Yeah, well, I don't know why we can't have signs in our facilities that say, if you're going to be abusive, you're not welcome here. No, it just says it will not be tolerated. That's not, you'll be discharged. One of the issues is absolutely should be zero tolerance for abuse by a family member. The nurse in Moncton was choked for 11 minutes by a patient's husband. So that's just she'll probably never nurse again. Like, she's traumatized completely. And the issue was they were moving his wife to a different bed. That's it. And he, anyway. So I think we have to get to a place where, you know what? Go home. If you're going to treat us this way, if you're going to be abusive, if you're going to be hitting, slapping, spitting on us, go home. But we're going to need support of people across from me to say, we agree with that. So when they go into your constituency office and say, you're never going to guess what they did to me at Dartmouth General. Yeah, well, you deserved it. So, because violence really gets me going, because it's very, very distressing to talk to a nurse. I was on a call-in show last week, and someone called in and said, well, you get paid a lot of money, you nurses, and right? So we have to change the attitude of Canadians and Nova Scotians. Like, I shouldn't have to take self-defense courses to go to work. We need security in our buildings that actually get involved and remove the person or remove them off me. Anyway, so your question about the changes within the Act, long time coming. One of the complaints I've always had about the College of Registered Nurses, and it was because of the Act, was their inability to be nimble. In order to get anything done, it had to go to change the Act, which, as you guys all know, takes forever. And so there is some really good things in that Act, like expanding the role of nurses without having to change the legislation, bringing in new and different types of nurses, like potentially psychiatric nurses, maybe, who knows? I mean, student nurses. I don't understand why we can't license student nurses while they're student nurses and have them work with us as a student nurse, not as a CCA or a PCW, as a student nurse in her 3rd year at St. FX. And she can come with me and give injections and put in a catheter and do all those kinds of, but no, they're working at Tim Hortons or they're working in the tavern, but it's because they don't have a license. So this new Act will allow that, and believe me, I'm all over that, because I really think we're missing an opportunity with our bright and the best. We need to get them into our facilities during their breaks so they get to know the staff, get to feel comfortable on the 3 North of the Sydney Hospital, where I think I want to come back and work here, because I had my daughter is working for the Irvings, and for 3 summers, she worked for them. And so it was just, to her, made no sense. Of course I'm going to go work for them, because I've been working for them for 3 summers. I know them all, and I'm happy here. And so I think we need to get there with our students. But if you're going to take them into long-term care and make them work as a CCA, that's going to drive them away from nursing, not to nursing. Really. I mean, they're not learning. And so I think that new Act is going to help with that. And the biggest thing is the nurse practitioners. It's the ability to change what they're allowed to do and what they're allowed to prescribe, and all those doesn't have to be so cumbersome.
Ms. DiCostanzo for less than a minute.
Thank you again. And actually, my question was more about the scope of LPNs and the new legislation that we passed to join the schooling, and how they can control the training for them. And actually, I had a very interesting question, because you said you graduated in 1984. I was going to ask you, did you do just the 2 years, or was your education 4 years? And how did we get, it was 4 years at that time, and now we're back.
Ms. Hazelton.
Okay. I'm so sorry.
Sorry, there was 2 programs then. There was diploma and the degree. I wanted an X ring, so I went to St. FX to get a degree. Honest to God, that's the truth. Because I was accepted in St. Martha's and at St. FX, and so I went to St. FX because I wanted an X ring like my brothers and sisters.
Time has expired. We'll move on to the PC Caucus for 9 minutes. Ms. Adams.
Thank you very much. And we just have 9 minutes, so I'm going to ask short questions, and hopefully we'll get short answers so we can get through as many as we can. I want to say that I am a physiotherapist, and I was on the VOM Board of Directors for a while, so I know that as the largest health professional group, nurses are the staple of our programs. I wanted to ask, when I was looking through the references, was the Nova Scotia Health Authority accreditation report reviewed, and were the items and issues that they identified considered when you prepared this report?
Ms. Hazelton.
This will be short. No.
Ms. Adams.
Thank you. And so I'm going to recommend, because there are some things in there specific to nurses, and that would be a good, I think, good thing to match up. The second thing is, in looking through the recommendations, I love the report. It's we're going to be able to reference a lot of information from here. Under the system dysfunction, I like a whole lot of it. I did have a question under recommendation 5. It says the Nova Scotia government should ensure that team members in all settings are able to practice autonomously according to their scope of practice and do not face barriers. So I'm just wondering, where the nurses shortage is well known, and I'll reference something else a little bit. How do the nurses feel about, they're already short-staffed, they're already staying too long. How do they feel about expanding their scope of practice when there's already a shortage of them, compared to, say, expanding the scope of practice, or say the pharmacist to do prescribing, or physiotherapist to see back pain patients in Emerge? And I'm just wondering how the profession feels about expanding the scope of practice when they're already feeling tremendous pressure to do things that are already within their scope of practice.
Ms. Hazelton.
They're excited. They're very excited, because I'll take an Emerge nurse, for example. You know, they have to look at that patient with a UTI for 6 hours, knowing full well, if I could just write an amoxicillin, you know, if I could just write a prescription, they'd be out the door and gone. And so they know how to do it now. They know. They just need someone, so they know. When I worked in Emerge, I know this is a UTI. Like, I know all he needs is an antibiotic. If I could write it myself and give it to them, but I'm not allowed. So they're excited because they know this is going to improve the care that they give.
Ms. Adams.
Thank you, and I agree that there are certain medications, because pharmacists are allowed to prescribe those as well. So I guess what I'm wondering is, where a pharmacist has a 4-year degree in prescribing, and we don't have a shortage of pharmacists, why we wouldn't be expanding their ability to prescribe where we have their expertise. They may not have the same assessment skills as nurses, for sure, but does the union acknowledge that we should also expand and maximize the scope of practice of all of the other allied health professionals, and that they may also be able to pick up some of the slack that the nurses just aren't able to do?
Ms. Hazelton.
I really can't comment. Because, you know, I don't know all of what a pharmacist is taught, or I have no idea the extent of, but I do know that a pharmacist at Lawton's can't do a urinalysis and come out with so my worry would be, if we, you know, you have a UTI, go to the pharmacy and get this prescription. Like, that's 2 stops when it could be 1. I absolutely think that pharmacists are doing a great job on flu shots and all those kinds of things, and reordering, but I can't comment whether their scope should be. There's not a lot of healthcare, not every healthcare professional has a scope of practice. Some do, some don't. CCAs, for example, don't have a scope of practice. They have a scope of employment. You know, in order to have a scope of practice, you have to be a regulated healthcare professional.
Ms. Adams.
Okay. I know you saw the look of surprise on my face, because as a health professional, we all have scopes of practice. I guess the pharmacists have a 4-year degree, and they have continuing education throughout their whole career. So what is the actual training going to be for an RN to be able to prescribe, and how does that compare to a pharmacist?
Ms. Hazelton.
So the actual writing of the prescription is the end result of what the registered nurses already have extensive education and training around medications, because we have to know this to give the medications. So I have to understand what each medication is to do, and how, if I give this with this, what the results will be. Our nurses already have a huge amount of education and continuing education on medications. You know, so if a doctor, for example, writes a medication for something, it's my responsibility as a nurse to make sure that the dose was appropriate, that that there was no allergy, that, you know, it was, so oftentimes our nurses are calling to say, you know what, this drug, it might be, you know, we might want to think about. So those kinds of conversations happen every single day all over this province in all our acute care. So the next step of actually writing the prescription, I'm not seeing it as that huge a jump, because we already know what amoxil is going to do, why the amoxil is getting ordered, how often the amoxil should be taken, because we're the ones giving it if they're in the facility, like TID with meals. Like, we know all this because that's what we do.
Ms. Adams.
Okay. I think that there are thousands of medications, and I think that physicians who are prescribing those medications and the pharmacists who took the 4 years of training may have different thoughts on where all this fits in and who is the best first point of contact for prescribing. And I think that's a very significant conversation that needs to go on. But I want to move on to recommendation number 14. It says, given that nurse practitioners have an autonomous scope of practice when population metrics or recruitment challenges warranted, the Nova Scotia Health Authority should allow clinics to operate with a nurse practitioner as the highest level of provider. Are you referring to publicly funded clinics or privately funded clinics?
Ms. Hazelton.
Publicly funded clinics.
Ms. Adams.
Thank you. Under recommendation 16, where it talks about to improve access and efficiency, the Nova Scotia Health Authority should empower collaborative practices to book nurse-only visits and visits with other health professionals based upon patients' individual needs. Is this not already happening, or do they all, because to my knowledge, they're not also seeing a doctor when they come into those collaborative practices?
Ms. Hazelton.
So it's not just nurse practitioners. There's family practice nurses that are involved in this as well.
Ms. Adams.
Thanks, I'll clarify. So are you suggesting that family practice nurses, that the patient who comes in to see a family practice nurse should not need to see a physician?
Ms. Hazelton.
Sorry. So where the nurse practitioner is working in a fee-for-service, so she's working with a GP in Clinic X, and the physician is a fee-for-service, she can see, she can treat. The physician currently has to sign off. So they have to sign off if it's a fee-for-service.
Ms. Adams.
Thank you. The clinical nurse practitioner training program, does it include emergency department training?
Ms. Hazelton.
Not typically. And what we're referring to in the emergency department is the people that aren't emergency patients. So your 4s and 5s. So your 4s and 5s are probably, you know, I'm guessing, a large majority of the patients that are...
Order. Time has elapsed for the PC caucus. We'll move over to Ms. LeBlanc for the NDP. 9 minutes.
9 minutes, okay, thank you. I'm going to move on to also a couple of questions about system design and dysfunction. I just wanted to ask you about the nurse-only visits, again, and how they are billed. So if I understand correctly, in a collaborative practice setting, even if a patient only needs to see the nurse and not a doctor for something, for instance, like a wound redressing or whatever, a changing of the dressing, that patient is still slotted in to see the doctor so that the visit can be billed for. Is that correct?
Ms. Hazelton.
In the fee-for-service ones, yes. In the others, like there's, I believe, a clinic in Pictou. I believe we have 2 or 3 three and 2 physicians, but the physicians are salaried. Yeah. So in that situation, they don't have, the nurse practitioner sees, treats, and releases. If it's a fee-for-service, my understanding, what I'm being told is the nurse practitioner in a fee-for-service has to have a sign-off by the physician.
Ms. LeBlanc.
Thank you. So it would be fair to say then when the province was implementing the collaborative practice model and began to integrate more nurses into primary healthcare settings in collaborative practice teams, someone essentially forgot to update the billing model to reflect this collaborative setting. Or is the issue that nurse-only visits are not being embraced by the other practitioners in the team? Can you comment on that?
Ms. Hazelton.
So, all of the newer collaborative practice ones that most recently, they are all designed so that the nurse practitioner can see, treat, and release without having to be seen by the physician. There are still some that are out there that are as you suggest, the physician has to see them.
Ms. LeBlanc.
Thanks. And when you say newer, you're referring to sort of like the NSHA turnkey model where the NSHA is the employer of all of the folks in the clinic? Correct, okay. And so in the situation of collaborative practice teams, I understand that the nurses are generally, well, yes, employees of either the NSHA or the clinic, and that their salaries are covered directly by the doctor operating the clinic, or this is the fee-for-service kind, or the NSHA, excuse me, transfers a certain amount to cover the nurse's salary directly. So that's correct in the fee-for-service?
Address the chair, please.
Oh, sorry.
Okay. Ms. Hazelton.
So my understanding is if the nurse is being paid by the health authority, they're able to independently without sign off from a doctor. And that's not just nurse practitioners. It might be a registered nurse, for example, that gives sex education. She could do it, and if she's in a clinic that she's not salaried by the health authority, she has to get that education signed off by the physician.
Ms. LeBlanc.
Thank you. And so now when you say address the chair, you mean do I say can the witness?
You asked, you don't say you, or
okay.
You address the
I'm interested in hearing the witnesses' thoughts on this setup and whether one situation, one way is better than the other, or what generally works better for the nursing profession and the people of Nova Scotia.
Ms. Hazelton.
So my view is that nurse practitioners should be employees of the health authority. I think they need to stay in a publicly funded, publicly administered healthcare system. I would be disappointed if there came a time where they were able to charge for their services. They are in Newfoundland, and it's become an issue in that, some of our most vulnerable people I need to see. So my view is they need to be, and that provides some benefits for them as well, like medical and a pension plan and right? So I think we're seeing the pushing and pulling and tugging now within the physician community when they're some are going to a salary and some are on a fee for service. So I think we should avoid all that with our nursing profession and just leave them all as employees of somebody.
Ms. LeBlanc.
So, thank you. Related to this, your report mentions the need for a dedicated stream of funding for chronic illness support and case management in primary care. This sounds to me like a great idea. How would you envision this working, and are some clinics already funded to do this?
Ms. Hazelton.
Yes, there are some clinics funded, but not enough. And I think we need to look at all of our chronic diseases, and even some of the clinics that we talked about that are nurse-led clinics. That might be a nurse-led clinic in Truro. But we might look at, and I keep saying Cape Breton, but we might look at Cape Breton and say, you know what, Glace Bay may need a different kind of healthcare professional in that clinic. Maybe a nurse practitioner, but maybe a social worker, or maybe whatever. So I think we have to look at the needs of every community in this province and say, okay, if we're going to set up a clinic, who needs to be working in this clinic? So if it's in a community that has a lot of challenges around addictions, well, obviously we need some specialists that deal with addictions. And if we have a very senior population with chronic illnesses, maybe that clinic has to look at that. I think we should have seniors clinics all over this province where they could go, they could sit down, they could chat with a nurse, they could chat with a physio, because just because you're 92 and you can't walk on a treadmill doesn't mean you don't walk. And how do you walk? And how do you lift? And what about nutrition? I can't eat like I used to, so let's make sure our seniors are eating the right foods. And so I think that would be a huge bang for our buck if we developed all of these clinics with VON nurses, but not just nurses. There's all kinds of other healthcare professionals, physiotherapists. Many seniors think that they can't do certain exercises. Well, nurses are not going, but physiotherapists would help. So I think we have a huge opportunity in this province.
Ms. LeBlanc.
Great. After-hours care is obviously a huge issue. People are often unable to access primary care because they can't get out of work, or because they work odd hours and are sleeping at that time, or because they have caregiver responsibilities, and the list goes on. Why we can't go to a clinic between 9 and 5. So it doesn't really the 9 to 5 schedule doesn't really accommodate everybody, and but we need to ensure that just because the fact that when you work shouldn't affect or determine whether or not you get access to care. Can you speak a little bit more about why nurses are uniquely positioned to help expand access to after-hours care?
Ms. Hazelton.
Because that's what we do. Like we're 24/7, and that's what we do, and we're used to it. And ironically, after a certain hour, we do it all. We do all the pieces of care that others would do maybe in the day shift. So, and nurses are keen. They're keen to do this. They're excited about the potential changes that they see happening. They want to be able to go see Mr. McDonald with a swollen foot before Mr. McDonald's swollen foot gets him in the hospital with congestive heart failure.
Ms. LeBlanc.
How much time?
2 minutes.
I'm getting different information. Nurse-to-patient education is another topic that was glad to see come up in the report. Do you have any sense of how we can quantify the amount of time that's needed above and beyond what's currently available in order to provide adequate nurse-to-patient education and general counseling? I guess I'll leave it there. It sounds like I'm out of time.
Ms. Hazelton.
So I think it depends on the individual. Everybody has different learning needs. Everybody learns differently. Our seniors learn differently than our younger people. So I think we have to look at the population, but it's a big gap. We don't typically in acute care in most of our units, we don't have a whole lot of time to teach anybody anything. So that has to be kind of built in. The softer side of nursing sort of has disappeared because we're too busy doing the busy stuff that we have lost the, so how are you doing, how are you really doing? We've kind of lost some of that.
Ms. LeBlanc. The 5 seconds.
Okay, thank you. Thank you so much for your comments. I really appreciate them.
Order. Time has elapsed. We'll turn it over to the Liberal Caucus. Ms. Di Costanzo.
Thank you, Madam Chair, and I'm really glad to go back to my question that we started. So you graduated in 84, and at that time most nurses studied for 2 years. And that was unusual that you went, it's almost like the master nowadays, correct? So if you can help me understand, how did we get within 30 years now from a 2-year program that was sufficient for nurses, that was really the standard, to a 4-year program? And now we went back kind of thing with the last 5, when did LPN start to become more, we're going back to the 2-year program and we're producing. And I know you said that there are 600 nurses that were just graduating. Is that RN or LPN or a mixture of the two? How is the scope and where do you see the vision for LPNs and what they can do and how is compared to the RN? Will the RN become the managers kind of thing? And how, it has become so much more of paperwork that the RNs are responsible for, and the LPN are more the bedside nurses. Am I correct? And what is the vision and how do you see it? Thank you.
Ms. Hazelton.
So no, you're not correct. Depending on the practice environment is the skill mix. So our ICUs and emergency departments are highly acute individuals are generally 90% or more of the time looked after registered nurses. Our more stable medical patients, depending, could and may be looked after by a licensed practical nurse. It depends on the patient. So typically what happens in our acute care facilities, the registered nurse most often will make a decision on who's going to look after who and why. So they may look at patient X and say, the skill set of, and let's be clear, every LPN doesn't have necessarily the same skill set, and every RN doesn't have the same skill set. I was an emerge nurse, don't put me in a CCU. So it just depends on the skill set of the nurse. And the 4-year program was a decision of the Canadian nurse. association, and the reason for it is because our patients are more complex. The skill set that we require is more advanced. And they believed, it wasn't a decision of the unions, obviously, they believed that they required more education. And they required, at that point, more university education, because at that point there were schools of nursing, and a lot of their time was task-orientated. So the registered nurse, the diploma, were task-orientated in the 2-year diploma. And so someone made the decision that we wanted them to have more formal university education, like your chemistry and university chemistry, university. So we didn't have a lot to say about that decision, but it's been made, and it is what it is.
Ms. Di Costanzo.
Thank you again. And just wanted to understand what's the vision for LPNs in their capacity and scope, according to you? Where do you see them, what they can reach, and what other things can they do, and how far can they go? I'm excited about LPNs, as you can see. Thank you.
Ms. Hazelton.
Oh, yeah, and we're excited about the increase of the LPN scope as well. The LPNs, when I first started nursing, they didn't give out medications, they didn't do physical assessments, they didn't do, and now they are. The RNs didn't do, and now they are. I'm sure physicians have increased their scope as well. I'm not 100% sure of that. But, in that, though, when we increase the skill sets and we increase the expectations, we have to also have a conversation about compensation. So, that truly is, there is an area there within the LPN. The difference between an LPN and a CCA is not very much, and the responsibility is significant. So, I think we have to be cognizant every time we increase the responsibilities and the expectations of any profession, not just nursing, that we appropriately compensate them for it.
Ms. Di Costanzo.
Thank you, and I leave it to my colleague, Ben Jessam. Thank you.
Mr. Jessam.
Thank you, Madam Chair. Through you, I just want to go back to the commentary around the challenges that are existent for, I forget the exact, acronym, but for a nurse to advance. Ms. Hazelton had indicated that it was fairly straightforward if someone could afford the time to actually take the course to advance themselves, citing challenges around childcare and proximity to our schools. Through the chair, I'm wondering if Ms. Hazelton could comment on whether there's been any exploration around a satellite program or anything of that nature, acknowledging that there are components, I would suspect, that are required to be on site, but Ms. Hazelton could provide a response to that. That'd be great.
Ms. Hazelton.
So currently, the LPN program at St. FX offers, for LPNs, it offers an accelerated, which you actually physically go to St. FX, and it's Monday to Friday, but they also have a online. So they have that. The nurse practitioner program, they're either started or they intend to start having that available at the Cape Breton University. So because it's hugely inconvenient for someone to leave a home that's 3 or 3.5 hours away, especially if they have children. I mean, that's the reality of it. So yes, there is plans. I'm not sure about the nurse practitioner. And Yarmouth has a satellite clinic out of Dal. So it is a satellite clinic from Dal, and I think there's 30 or 40 students down in Yarmouth that are Dal. The Dal campus. It's called the Dal campus.
Mr. Jessam.
Thank you for that response. With respect to educating the public about the potential and the scope of nurses, and I'll cite a couple of different instances in your recommendations with respect to the suggestion around in-home checkups for patients that are more than 75 years old, and the use of telemedicine and other formats. Dare I say that some people are fairly entrenched in the way that they have accepted healthcare, and a requirement for us to morph into something more modernized it's there. It has to be there. I'm wondering how important, through the chair, that is to the public education component is to what we're trying to accomplish here.
Ms. Hazelton.
So I think that's why we did our TV ad, was because it showed a nurse practitioner writing a prescription. It showed, and that's what we're trying to impress upon Nova Scotians, that there's enough work in the system for all of us. There doesn't need to be competition between healthcare professionals. There's plenty to do. There's lots to do, and we just have to make sure that we're using the most appropriate healthcare professional, depending on the client's needs or the patient's needs. So, you know, I think we do have to change, but there's not many people under the age of 60 that don't have a smartphone. Now, granted, 60 to 80, we may find some, right? And so those individuals are going to be 80 very soon, and so how can we utilize the technology that they're carrying around in their pocket to better our healthcare needs? I mean, you know, your Fitbit now can tell you your blood pressure and your... So I think we're going to get there one way or another. It's going to happen. And people are going to start demanding to know what their blood work is. Like, they're not going to want to go see their doctor to see what their blood work is. Why should I have to? Email it to me, text it to me. So I think if we don't get ahead of this, they're going to go right over top of us, and they're going to start demanding. So we need to be leading this charge, not catching up like
Order.
we do.
Time has elapsed. Thank you very much. Would you have any closing remarks, Ms. Hazelton?
You know, I think that it's important that no matter who we are, we're all Nova Scotians. We're all going to have to access this healthcare system that's being created at some point in our lives. If we haven't already, we're going to. Or our parents are going to, or somebody is going to. We need to find a way, everyone, to work towards some solutions to this healthcare issue that we find ourselves in. And, you know, everybody in the system needs to be involved. Everybody needs to have whatever piece of their world they need. But we can't not do something, and I truly believe some of these recommendations, and many of you have the ability to make it happen, has to happen. And we need to do it now, I don't want to be back here 5 years from now saying, yeah, well, you know, we had 35, there's 2 done. These are doable, they're affordable, and they need to happen to improve the health care. We want to keep our seniors in the home, then we got to make sure that they have the supports in place to stay at home. And some of these things will allow our seniors to stay at home, be looked after at home. There's too much pressure on patients' families right now to provide the care that, quite frankly, I believe not just nurses, but others can provide within the homes.
Thank you very much, and thank you, Mr. Curry, and Ms. Hogan, for coming today, and thank you for the report. And a special thanks to our clerk, who went out of her way to try and find a date for us to, I think this was probably the most challenging meeting date to set up, that you were available, Ms. Hazelton, and your co-workers and members of the committee, because I know there were some events going on that some members could not attend. So thank you for being here. You may leave, and we have 2 items of our committee business. If you look at your correspondences, we have a request from the Canadian Cancer Society to appear before the committee. And we also have a request for the Nova Scotia Health Authority for additional witnesses. We'll deal with the request from the Canadian Cancer Society. I'm just looking for my papers. Okay. They've asked to appear. I'm wondering, when is our next agenda setting? We're scheduled for how many more meetings? Yeah, so can we add this topic? Is there when we do have our agenda setting, that the Cancer Society come to be put on that list? On the agenda setting? Yes. Are we in agreement? We're in agreement, so. Our next piece is a request from the Nova Scotia Health Authority for additional witnesses at the July 9th meeting. You all received correspondence. Dr. Dunbar did not make this request, but has told the committee the clerk has no objection to these additions. So, any comment, or are we in agreement with the extra? Okay, that's great. So we will put them on. And our next meeting date is July. Ms. McFarland?
Thank you, Madam Chair. May I have a point of order I would like to?
Oh, yes.
I just want to clarify that at no time during this presentation when I spoke that I said that I endorsed the 35 recommendations. My colleague to the left of me from the Liberal Caucus indicated that she was surprised that the PC party endorsed all 35 recommendations. That is incorrect. I would ask that perhaps we go through Hansard and prove that I did not say that the PC party endorses all 35 recommendations. Thank you.
I would have to refer to alleged counsel about that because I do not know. We'll take a short recess. I've been told by order. I've been told by the clerk it's not a point of order. It is just something that the committee can agree to do or not agree to do. Ms. McFarland.
I would like to have a motion put forward to prove that I did not say that the PC party endorses all 35 recommendations. Thank you.
Mr. Jessam.
If the honourable member would like to produce the transcript, we can look at it next meeting, and whatever's in the transcript, it's what's there. Yeah.
Okay, so we will leave it for we will put it on the agenda for the next. No, she said I would like to have a motion. She didn't say I will make a motion. So can you read? Ms. Adams?
Thank you. I think it's really important that what we are saying is accurately reflected by other members. So I'm going to make a motion that this committee, the motion is that I would like the committee to bring to the next meeting a copy of the transcript of what Ms. McFarland said and what Ms. Miller said, so that we can ensure that what our party has said is accurately recorded and referred to.
Okay, there's a. You're asking for a recorded vote? Okay, there's a motion on the floor for a recorded vote. Oh, so. We will have a recorded vote. We will begin with Ms. Martin.
Yes.
Ms. LeBlanc.
Yes.
Ms. Adams.
Yes.
Ms. McFarland.
Yes.
Ms. Miller.
Yes.
Mr. Jessam.
Yes.
Mr. Irving.
Yes.
Ms. DiCostanzo.
Yes.
Okay, the motion is carried. We will have that prepared for the 9th. Maybe the, well, we'll all get a copy of the transcript anyway for our own viewing. So there being no further business, our next meeting will be July 9th from the hours of, I'm looking, 1 to 3 p.m. Our witnesses will be Dr. Michael Dunbar, orthopedic surgeon at the QE2 hospital. I call the meeting to be adjourned. Thank you.